This is an easy method to treat the pylon fracture or fracture dislocation of the base of the phalanx. This is one of the methods. In the next presentation, Dr. Bigazzi talk about the AG. I'm talking about this method. It's done by Kirchner wire, and I show you it's very easy. Our goal of treatment is let the patient move the quickest as possible with a stable fixation and give an early motion because of the soft tissue that is important. The frame has been described by Suzuki many years ago with two Kirchner wire in the second phalanx and one in the head of the first phalanx. But we can do the same without the two Kirchner wire, only one. Then we can use elastic band to give the tension, or bending the key wires that I show you this technique today to have the dynamic movement. So this is the fracture we have to treat, and what you do not see here are the elastic in the phalanx. So this is the picture from the literature, and the key is the first key wires that is in the head of the first phalanx. Then the second is at the middle part, and the third is at the end of the second phalanx. This is if you want something very stable. Normally I use these methods only with two wires. This is described very well by Badia in 2005, and I show you the technique that we go to do upstairs. So this is what we want to reach. A key wires proximal, parallel to the rim, and the second one distal. This bending create the distraction, so there are not elastic band and easy to do by yourself. It's important that the Kirchner wire has to be 1 millimeter, 1.1 and 1.2. 1.2 for big guys of 60 years old. 1 millimeter is a young girl, very lax and smooth. So please don't use 1.2 in lax girls, because otherwise you have a distraction of the joint too much. And normally in this joint you have also a problem of ligament. So pay attention to not distract too much. Some technique. We need to put the first wire in the center of the head. This is the most difficult part of the operation, because the Kirchner wire is long and not so easy to do that. Then parallel to the joint. The second wire arrive where we want, so it's not important where do you put the second wire, but on the neck. But it's important that it's parallel to the first one. At this point, we can, the second wire has to be long. The first one can be short. Then we bend the two wires of 90 degrees. We leave 3-5 millimeters from the skin because there is a swelling after operation, so please leave the 5 millimeters. 90 degrees, the first one and the second one. The distal one has to be longer, 1 centimeter more than the first one of the head of the phalanx. Then we use the AO flex key wire, and we bend the distal wire, and this is the tension we have at the end. So pay attention not to put too much tension. Then you do a hook in the distal one that arrive to the first one. It's much more easy to do than to explain. And at the end, this hook and other pitfalls that can happen that the patient doesn't see, and this go away. So do that. Try to do the hook and close the hook on the key wires. At the end, the patient has able to move actively in the operating room, looking at what he is doing, so he can repeat after the operation the same movement done in the operating room. This is 1 week after. We have to teach how to do to the patient, and normally I will show you after. Main pitfalls is that you have to do X-rays 3-4 days after the treatment, because if the stress is too much, you have to solve the problem and reducing the dynamic distraction. This is much more easy method to treat this kind of fracture. The name of this is extension block pinning technique. You put a key wire on the dorsal part of the first phalanx, and then you leave the patient to move. And this is very useful if you have late presentation of unstable fracture, or at the end of the procedure with this frame that I show you, there is a dislocation dorsally of the second phalanx, or alone. It's very quick, it works very well, and is described many years ago, and permit the patient move, and you have not to do a frame. This is another article, so you can really have all the literature about that. This is very easy, quick, and useful. Then we have other possibility not to do all these bendings. These are products that are sold in Italy. I don't know if in your country, but this is very easy, and the distraction is really controlled. Because if you do by yourself, the control is not so good. I want to cite a work of Thomas Giesen that gave the same frame, but for the base, the fracture of the base of the first metacarpal and around the fractures. So you can use the same frame into the trapezium to distract a phalanx of the base. Which are the pitfalls? The distal wire should be tied to the phalanx. So I had a problem when I tried to change a Kirchner wire with one other a little bit smaller. If it moves in the day before, it can move all the frame. It is a big problem. So don't do many holes with these wires. Has to be stable. Pay attention to the tension. X-ray 2, 3, 4 days after the procedure, so to see that there is not too much distraction, and the patient has to move immediately. Thank you very much for your attention.